Hi, can everybody hear me?
Yes.
I'm going to turn. Great. I'm going to turn this over to Gopal.
Hello, everyone. This is Gopal Khanna, Director of AHRQ. Thank you for joining our entirely virtual NAC meeting. This is first of its kind. I wish there was more important and positive reason for having this kind of meeting, but as COVID-19 continues to disrupt so much around the country and around the world, we want to make sure we are keeping everyone safe and taking all the precaution we need in doing so. These are incredibly trying times, and I know many of you are at the front lines of responding to this crisis. So I want to sincerely thank you for carving time out of your busy schedule to be with us today. Given the importance of today's meeting, I don't want to waste time getting started. So at this moment, at this time, I'd like to turn to our new NAC Chair to call the meeting to order and provide NAC member updates. I asked Tina Hernandez-Huza to serve as chair, and I'm excited that she accepted. Tina, please.
Thank you so much, Gopal. It is a pleasure to have this new role as the chair of the NAC Committee for AHRQ. So I'm excited to be here, and I'm excited to move this meeting forward in an efficient manner. Can we go to the next slide, please? Yes, so first I would like to call the meeting to order today. And so with that, I would like to start with some updates on our current NAC members. Of course, as I said, I'm excited to participate as the new chair, and we have a lot of current members who have new positions and roles, and we are excited that everyone is moving forward in their positions. We also have many new members that have joined NAC for the first time for this meeting. Next slide, please. So our new members are Asaf Bitton, Gretchen Dahlen, Susan Edmund Levatin. Please excuse me if I mispronounce your name too. Omar Latif, Hoangami Hu, Ramanathan Raju, Patrick Romano, and Yangling Yu. So with that, I would like to go through our roster or our people here on the call today. And if you could please just everyone, NAC members, introduce yourself and just identify your area of interest or focus. Because we are virtual, I will go through the names of our members. And if you can please just, again, introduce yourself. So we're going to start with Gregory Alexander.
Hello, can you hear me?
Yes.
Hi, this is Greg Alexander. I am a new faculty member as of March 1st at Columbia University, and my area of research is in long-term care, quality improvement, and health information technology and health information exchange. Thank you.
Perfect, thank you. Karen Amstus. Do we have Karen on the line? Okay, we'll try and go back to Karen. Asaf Bitton. Okay, maybe some people are having some issues connecting or just a little delayed, so we will move on. And please text Jamie if you come back on while we're doing roll call, and we'll be sure to go back to you. Kathy Bradley.
Hello, I'm Kathy Bradley, the Associate Dean for Research at the Colorado School of Public Health and the Deputy Director of the University of Colorado Cancer Center. My area of research, health economist by training, and I look at the economic outcomes of chronic disease, specifically cancer, and connections to employment and health insurance, and also do disparities research.
Thank you, Kathy. Gretchen Dolan.
Yeah, hi, I'm Gretchen. I'm based in Wisconsin. I'm a healthcare administrator and consultant, and I have Consumer Health Ratings website, which tries to get consumers usable information on cost and quality of healthcare.
Tina, Karen Amstos is now on.
Great. Karen, can you please give us just a brief introduction and your area of focus? Thank you for joining us today.
Sure. Thanks, Tina. This is Karen Amstutz, and I have assumed a position as Vice President of Community Health for Indiana University Health. We are committed to reimagining and extending our approach to health, starting with ensuring that we have all of the foundational services and models of care and extending out into behavioral, environmental, and social determinants work as well.
Great. Thank you. Beth and Doherty.
I don't think she's going to be able to make it.
Okay, thanks. Susan Edgemond Leviton. Do we have Susan on the line? Okay. Peter Emby.
Hi, can you all hear me?
Yes.
Great. Peter Emby. Hi there. Peter Emby, President and CEO of the Regent Street Institute, Associate Dean at the IU School of Medicine, and Vice President for Learning Health Systems at IU Health.
Thank you, Peter. Christine Goschel. Christine? Okay.
Susan Edgemond Levitan. I was muted. Could I jump back in?
Absolutely. Please do.
Thank you. I'm the Executive Director of the Mass General Stokel Center for Primary Care Innovation. And my areas of research are, I've been one of the investigators on the CAPS Consortium since its inception in 1995, and I focused on measuring and improving the patient and family's experience of care, and also patient safety and patient engagement, and primary care redesign.
Great, thank you. Let's see,
This is Chris Goschel. Can you hear me now?
Hi, Chris. Yes, we can. Thank you.
I'm sorry. I think there's just a little delay when you take yourself off mute. I am the Assistant Vice President at the MedStar Institute for Quality and Safety, a registered nurse and professor of medicine at Georgetown University. My areas of focus are quality and safety, and particularly diagnostic improvement, where I'm currently doing research.
Perfect. Thank you. Has anyone else joined since that we missed? Okay, we'll move on.
It's Mondo Robinson here. Sorry, I don't know if I
Okay, we're going down to look at you, Mondo, in just a sec. Okay.
Okay, no problem.
Perfect. Okay, next we have Rahul Gupta. Okay. We'll move on. Charles Can. All right.
I don't think he can make it.
Yeah, okay, perfect. So Charles is not here. Okay, Amar Latif.
And he'll be joining us a little later today, I think.
Perfect. Andrew Masica, sorry.
Yeah, good afternoon. Hello.
Hi, perfect. You want to give us just a brief introduction and your focus of interest?
Yes, no, Andy Masica. I'm the Chief Medical Officer for Texas Health Resources, and like a lot of you, buckling down for the weeks that lie ahead.
Right, right. Okay. Long May who?
Hi, it's Mai Pham. I'm Vice President at Anthem, responsible for value-based care. I was previously at the Innovation Center at CMS, and so my focus is on delivery system and payment reform, as well as primary care.
Great. Sorry about the name. Yes. Okay, moving on. Ramanathan Raju.
Hi, good afternoon. I am Dr. Ram Raju. I'm a surgeon by profession and a professor at the Hofstra University in New York. My primary interest is social determinants of health and health equity through social equity and health literacy.
Great, thank you. Edmondo Robinson.
I'm here. Sorry, I joined late, so I wasn't sure where you were on the list.
That's fine.
Edmondo Robinson. I am the Chief Digital Innovation Officer at the H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida. My area of research focus is transitions of care, as well as the impact of technology innovation on care delivery in some new areas now, including artificial intelligence and machine learning.
Great, thank you. Patrick Romano.
Yes, hello. Sorry, I had a little trouble getting back into the WebEx here, but I'm a general internist and a general pediatrician based at University of California, Davis Health in Sacramento, California. I'm a health services researcher. My work focuses on healthcare quality measurement and particularly the development, validation, refinement, and application of quality measures that are used in various programs. I also have an extensive history working with AHRQ, going back to a fellowship, postdoctoral fellowship training in what's now called the T32 program, a career development award, an R01, and a series of contracts working particularly with the HCUP program, the Healthcare Cost and Utilization Project, and the Quality Indicators program.
Great, thank you, Patrick. A lot of work with AHRQ. Next, we have William Schrank. We have William on the line. Okay. Yangling Yu. There you go. I was going to say, I see you connected.
Can you hear me?
Yes, now we can.
Oh, yeah, I'm sorry. I'm a research scientist at the University of Washington. And because my dad died of medical error, and I have become patient safety advocate. And since then, we have formed a local patient safety organization called Washington Advocates for Patient Safety. It's a nonprofit located in the Washington state. And our work, I primarily focus on promoting patient-centered care, team care, and improve communications between medical providers and patients and families, and also to improve care quality and safety and transparency. I served on AHRQ last year, and I have been reappointed this year. So thank you for having me back.
Thank you. Has anyone joined any of our NAC members who have not yet introduced themselves?
This is Mike Lauer. I am the NIH Deputy Director for Extramural Research, and my background is in cardiology and clinical epidemiology. Thank you.
Thank you. Okay, so also I'd like to let you know that Paul McCann will be joining us today instead of Sherry and David Atkins instead of Naomi for our NAC officials. Sorry, I'm reading between things. And anybody else joined recently that did not get a chance to introduce themselves for our NAC members? And I forgot to introduce myself, so I would like to take a moment to introduce myself. As Gopal mentioned, I'm Tina Hernandez-Boussard. I am an associate professor at Stanford University in the Department of Medicine, Biomedical Science, and Surgery. My focus is on, well, my background and training is in computational biology, and I also have degrees in health services research and epidemiology. I've been working with our electronic medical records for about a decade now at Stanford, and so my team really focuses on how we can pull together not only EHRs, but other sources of very large data sets, connect these data sets to generate hypotheses, to understand care delivery, comparative effectiveness research, and really to evaluate the quality of healthcare delivery. So happy to be here, and we have, as you can tell, a very broad range of expertise on the NAC, which makes us so strong. Thank you all for being here today.
Hi, I just wanted to let you know.
Okay, so, sorry, I'm just going through these. Okay, so do we have any other NAC officials, ex-officials on the line, executive officials on the line?
Hi, yes, this is Robin Wagner from CDC. I'm the Chief Science Officer. Hi, can you hear me?
Okay, so please, if anybody else joins, let us know. I would like to remind NAC members that if they would like to make a comment or ask a question during the meeting, to please text Jamie Zimmerman. Her number was sent out to you along with the NAC materials early this week. We have unmuted all of the NAC members' lines, so we would appreciate if you could mute them on your own so we don't hear background chatter. If a non-NAC member would like to make a public comment during today's meeting, please send an email no later than 2 p.m. Eastern Standard Time to National Advisory Council at ahrq.hhs.gov. And that is spelled out completely, no spaces. National Advisory Council at ahrq.hhs.gov. And comments should be limited to 3 minutes each. Okay, so we will move on to the first order of business. First, I would like to ask for any changes or edits to the draft minutes from November 21st, 2019 meeting. If anyone has any edits or changes, please email Jamie. If none, I would like to ask for a motion to approve the minutes. Can we get a motion to approve the minutes?
So moved.
Second.
Somebody will have to unmute and give me a motion to approve the minutes, please.
So moved.
Approved.
I heard a move in a second. Tina, did you hear that?
Can we, Does anybody have any, well then let me go back. Does anybody have any comments or edits for the minutes from the November 21st meeting?
Tina seems to be having technical problems.
Okay, can we get a motion to, oh, they approved. Okay, thank you. You're texting Jamie. Can I get a motion to second, please?
Second.
Yes. Tina, I think you may not be hearing us.
Tina's audio doesn't seem to be working.
Hold on, I'm having some problems with my audio. I can't hear. 1 second. Sorry, just 1 second. I'm having problems with my audio. I can't hear. Let me just see. Okay, I'm going to move this to Jamie while I fix my audio.
Okay, so this is Jamie. Hi, folks. I'm the designated management official for the NAC, and with that, we're going to turn this over to our director, Mr. Gopal Khanna. Next slide, please, Jen.
Well, thank you, Tina, for getting us started, and thank you, Jamie, for your help here. I know this is our first totally virtual meeting, and there will be some rough spots over here as we go along. But let me come back and talk about today's meeting. I would like us to focus on 3 things. First, we will provide an update on AHRQ's budget and ongoing activities at AHRQ, including an update on the various activities we discussed during our previous NAC last November meeting. While circumstances have required us to pivot substantially, we nonetheless remain dedicated to our mission, and it's important for all the NAC members to know that. Next, we will provide a detailed update on our response to the COVID-19 crisis as an agency, department, and as a country. After the updates, we will turn the floor over to our NAC members for a deep dive into opportunities for AHRQ to further contribute to the national response efforts. Finally, we will round out the day by doing a deep dive into an initiative that is near and dear to my heart, AHRQ's 21st Century Care Initiative. As many of you know, AHRQ celebrated its 20th anniversary back in December, and in doing so, announced our 21st Century Care Initiative to rethink where we are as an agency and where we need to be. I will talk about this initiative after lunch, and I'm eager to hear your thoughts. At times, we in government have a habit of getting into our own cocoon, and it becomes difficult to break away from our routine thinking. What makes our NAC so important in that each of you brings a unique and new perspective to help us think differently about how AHRQ can grow as an agency. So I welcome your comments and input and insights. There are many areas that AHRQ is having an impact. What we want to hear from you is where AHRQ should expand or redirect our efforts in order to go even further. I'm also asking you to think creatively about strategies for scaling our efforts. Who should we talk to? What partnerships should we pursue, both within government and externally? And finally, I want each of you to think about how your role on our NAC can help raise our voice and elevate our work to the forefront of the minds of healthcare experts and policymakers. Who would be interested in AHRQ's work? Who should be interested in AHRQ's work? And how can we frame our agency in a way that helps them understand the value that we bring to the healthcare ecosystem? That's where I need your help. In a moment, I will turn over to my colleague Lucy Levine to provide an update on AHRQ's budget. Next slide, please. But by the way, before I do that, I would like to formally congratulate Dr. David Myers, who was recently appointed to serve as AHRQ's Deputy Director. David, I won't ask everyone to try to clap with a phone in their hand at this point, but rest assured, David, that everyone extends a round of big applause. You've been a phenomenal public servant, and we are glad that you are now a Deputy Director of AHRQ. And without further ado, let's go to the next slide and turn it over to Lucy for budget discussion. Lucy?
Hi, Gopal. Thank you. We have a packed agenda today. Good afternoon. Welcome to everyone. I'm going to give you a quick budget update before we move on to the rest of the agenda. Next slide. Next. Let me give you a summary of where we are right now. The fiscal year 2020 enacted budget provided AHRQ with $338 million. This is in discretionary budget authority. It's the same level of support as 2019. The money was provided in the following research portfolios: patient safety at $72.3 million, health services research, data and dissemination at $96.3 million. Within that total, $52.9 million will be devoted to investigator-initiated research grants. Of that total, $11.1 million will be in new. Our digital healthcare research and technology portfolio received $16.5 million. The U.S. Preventive Services Task Force, $11.6 million. The Medical Expenditure Panel Survey, $70 million. And finally, the Program Support category received $71.3 million. This is a good level for us. In 2019, we got a $4 million increase, and we were able to maintain that increase going into 2020. But the better news is coming on the next slide. The PCOR Trust Fund was reauthorized. The Consolidated Appropriations Act reauthorized the PCOR Trust Fund for another 10 years. It is expected that we will receive approximately $100 million per year, so $1 billion over these 10 years will mean we can do great things to disseminate and implement PCOR research findings, to assist in incorporating PCOR research findings into clinical practice, and to train and do career development for researchers and institutions. So that really was unexpected. We had hoped, but it was probably 50-50, so it was fabulous news. So a really great 2020. The next slide. In probably less exciting news, we submitted the FY 2021 President's Budget on February 10th. Like prior years, this budget transitions only the highest priority activities of AHRQ to NIH in a new institute called the National Institute for Research on Safety and Quality. Within this institute, we would be funded at $256.6 million in budget authority. That's a decrease of $81 million from our current funding level. The total program level, which means it includes the mandatory PCOR Trust Fund budget as well, would be $355 million. This is a decrease of $89 million from AHRQ's total program level in 2020. I will say we should all just take a deep breath. This is the President's request to Congress. Congress will now consider this budget over the next 6 to 9 months, and given everything going on, my my guess is we will be on a continuing resolution for 2021 for quite a while. But they will look at this proposed budget. The House and the Senate will make their own recommendations, and we will get a budget that won't necessarily be this budget. It will be what Congress deems is appropriate for AHRQ. And that's the budget update. Does anyone have any questions? If there are no questions, I'll turn it over to David.
Thanks, Lucy, and thanks, Jennifer, for sorting out the technical details and getting us all going. I think we can say this is a great example of AHRQ being nimble and solving problems in real time. So thank you to all of our NAC members and those listening on to this public meeting. My job today as the new Deputy Director is try to share with you some of the excitement that I have of all the great work that AHRQ is doing. And I'm going to organize this in the way I tend to think about AHRQ in our core competencies. So we're going to talk about some advances in health systems research, practice improvement, data analytics, remind us for a moment how all of those are not separate things, but we think of them collectively in improving the quality, safety, and value of healthcare. So some of examples of how we integrate that kind of work. And then there's a catch-all that I'd love to talk about at the end on operational excellence. But before I even get there, I'm going to tell you, we really had some big goals for working with the NAC at this meeting. We wanted your advice on how we think about the next 10 years with the P-Core Trust Fund. We wanted your advice on how we think about a strategic framework for our digital health research group. We were going to update you on the work we're doing in multiple chronic conditions and diagnostic error, things we've talked about in the past, but we wanted to show you our progress. And we were also going to talk with you about our work on creating a unified digital health insight platform for the agency. And coronavirus came and we've readjusted. So they said to me, could you do all of that in the next 20 minutes? So that's what I'm going to try to do at the end. But all of these topics are things we hope to come back to you, and we don't even have to wait till the next NAC meeting. We'd like to hear from you in between on your ideas, your perspectives on how AHRQ can increase its impact. Next slide, please. So health systems research. Next slide. Two of the areas that I chose to highlight here are two that are our wildly important goals. Strategic visions that the director challenged AHRQ to develop that we did over the last 2 years. And even without new funding, we are putting into place efforts to improve Americans' healthcare in, first, reducing diagnostic errors. That program, and you can learn about it more on our website, but we took the first steps with this through research grants to look at the incidence of diagnostic errors. How can health systems know that these things are taking place, and understanding what contributes to making them happen and what are the results of them. And the 4 grantees are looking at, I think, a nice selection of topics. Delays in diagnosing infectious disease, inpatient diagnostic errors, primary care-based errors, emergency department errors, and engaging patients and families in improving the process of diagnosis. Building on this work and as part of the larger work, and if Jeff was here and able to talk with you, he would tell you about a large national report that is about to come out. In conjunction with those two things, we hope to have later this summer, probably in August, a national summit on developing a national agenda for patient safety research to keep this moving forward. Next slide. Multiple chronic conditions is another one of our WIGs, and that one is really based on our idea that healthcare systems need to learn better how to defragmentize care and create patient-centered care that delivers sustained, high-value, coordinated, integrated care with a focus on primary care that optimizes not only individual but population health. This work is being led by Dr. Arlene Bierman. In 2019, we told you about a small first set of awards that were looking at how data could be used within communities, connecting healthcare systems and public health to understand chronic disease and care management in their communities. We followed that up. Right now, there is an opportunity on the street from AHRQ on improving quality and patient outcomes through care transitions that has both a technology component but a strong focus on improving care for the most vulnerable with multiple chronic conditions. Next slide. AHRQ takes our research and tries to help health systems and healthcare professionals understand the new findings and put them into practice, to use it, to operationalize it. And so here are some of the examples of the work we're doing in practice improvement. Next slide. A research grantee in Washington State, Michael Parchman, and his team worked with primary care providers, specifically in rural areas, to understand how they were and how they were not delivering medication-assisted treatment for their patients, and discovered that they needed a bigger framework for opioids prescribing as well as treatment. AHRQ took this research and partnered with them and helped them expand the research, test the research in health systems across the country, and that led to the development of this product called 6 Building Blocks, which is a structured, systematic approach for primary care practices to understand chronic pain, opioid therapy, getting people off opioids, as well as when they need to do long-term management. Next slide. Our CUS program, which is really a gold standard of how AHRQ has partnered with healthcare systems to understand culture and the application of evidence through tools and checklists. We used that project in the past year on appropriate antibiotic use and partnered with over 400 hospitals. This year, we're taking that work even further using the same underlying framework, but directing it towards combating antibiotic-resistant bacteria and specifically looking at MRSA infections both in ICUs, within hospitals, and in surgery centers. Next slide. Switching gears yet again, we have a lot of, I think, exciting work in practice improvement that we wanted to highlight today. This is a current funding announcement that is out there now, and we hope you'll help us spread the word. This is builds on our former Evidence Now work, but is targeting states as the movers of quality improvement, recognizing many of them don't have a standing infrastructure to reach out to primary care practices, something that in the time of COVID-19 we wish they already had. But we recognize this need and put out this funding announcement to build capacity in states to deliver quality improvement activities to primary care practices by linking together as many different state resources, including the State Department of Health, the State Medicaid Agency, academic institutions, primary care organizations, and consumer groups. This initiative will establish these cooperatives, build a learning network in states of primary care practices, do a specific project to move evidence into practice around heart health, conduct an evaluation on all of those 3 pieces, and then also, and probably most importantly, from the beginning, think about how to create a sustainable infrastructure so this work can be self-sustaining in these states moving forward. Next slide. Data and analytics are the 3rd pillar on which we build our work at AHRQ, and these are all related. Sometimes it is our data and analytic responses that leads to questions that we then do research on and help practices. Other times we do the research, we help practices improve, and we use our data and analytics to tell the country how we're doing in improving. Next slide. Our 2 main data sets at AHRQ are our 2 foundational ones. These are certainly not the only, but they are 2 of the most important, are the Hospital Cost and Utilization Project and the Medical Expenditure Panel Survey. On the screen, you'll see before you 2 brief analysis that came out of those data sets in the past year that focused on influenza. And it's an incredibly important topic today as we think about how does the health system respond to infectious diseases. So not only do these 2 briefs have meaning today in understanding our health system response, AHRQ is already working very closely with the department to use these 2 data sets to understand our response to COVID-19. Next slide. Our colleagues in patient safety have been running the patient safety organizations, a national effort to make it easier for healthcare systems to talk about, understand, and learn from both errors and near misses in healthcare, with the goal of all of us improving together and making this a non-stigmatized field. That work has been going on for a long time, but something very exciting happened this year. It all came to fruition when patient safety organizations for the first time were able to share their data nationally. And so we were released to the public the patient safety data, the network of patient safety databases. It has over 1 million standardized reports of errors that have happened around the country. And these were all voluntarily submitted. And we expect another 20 to 30% growth in this year as the data in the summer of 2020, we put the next tranche of data into this. And so we're really excited to see where this is going. And our team has already created tools that people on the website can use to do their own analysis of the data. Next slide. We heard a little bit about this earlier. The Compendium of U.S. Healthcare Systems is a project that is was trying to initially understand how healthcare systems use evidence to improve practice, but in doing so, we were able to create a map of healthcare systems, vertically integrated hospitals, doctors' offices, surgery centers, healthcare professionals associated with these systems. A little bit you can see here. The work was originally put out in 2018 using 2016 data. In 2020, we've just released an updated version of this with 2018 data showing the further consolidation and growth of healthcare systems. The largest healthcare system in the U.S. is a for-profit healthcare association, HCA of America, but there are many large religiously affiliated healthcare systems as well as nonprofit and public healthcare systems as well. The database currently, and this framework currently captures 70% or more of hospitals and over 50% of physicians in the U.S. Next slide. So when we rapidly talk about those, it can look like AHRQ thinks about these areas in silos, and I just want to ensure all our NAC members and those listening that that is not. AHRQ really does see all of this work as integrated. Next slide. So here's an example. Our data showed us that older Americans are actually showing some of the worst outcomes related to the overuse of opioids. And this probably has to do with the fact not that they are using heroin, but that opioid use in older adults who have other comorbidities, medical frailty, and many other medications may cause them to have side effects and end up in the hospital. And you can see on this chart the rapid increase of hospitalizations and ER visits for the oldest older Americans over the last 2 years. So our data showed us a problem. We went to the department and said, within our larger opioid response, who's looking at older adults? And the department said, no one. So AHRQ said, how about we try to help with this? We created an evidence map, which is a form of a systematic review to understand the problem. We've put out research grants that are currently being reviewed right now to look at how healthcare systems can deliver better and safer care to older adults to reduce the effects of opioids, and have actually started one project that's pilot testing actual management and treatment strategies in a healthcare system that we hope to be able to build in as well. So we're doing practice improvement, research, and data all together to address an important problem in America. Final slides. The reason we are spending this time with you today, normally we have much more time and we could do this a little bit more leisurely, but we don't like to talk about all the, or I think my staff don't like to talk about all the great work that they're doing every day. I'm doing this though for you today so that you'll have more of some fuel for the next two discussions we're about to have. And so we needed to give you a little bit more background, which on some other initiatives here at AHRQ that I wanted you to hear about. So next slide. The first has to do with a change. AHRQ had a program in health IT, and under Mr. Connor's leadership, really expanded our thinking and renamed the Division of Healthcare Research, trying to ask the question, how the various components of the overall and much larger digital healthcare ecosystem come together, and how we can harness them to affect healthcare quality, safety, and effectiveness. And you can learn more about this program and read the details of this diagram that's helping shape their thinking on our website. Next slide. One of the things we're doing right now, the name change just happened, the division, the people have been there, but they're reevaluating their roles and where they want to go. This is one of the areas we would have done a deep dive with you if we had more time with you today, but they are starting a strategic planning process, and I hope we'll be able to bring that back to you all in either your July or your fall meeting. But they're looking at all of AHRQ's work in quality, safety, value, our wildly important goals, MCC, data and analytics, improving diagnostic safety, and how digital healthcare and the future of digital healthcare, how AHRQ can steer that in directions to meet these larger challenges. Next slide. That reminds us, of course, that digital healthcare is one half of the equation. Data is a much larger set, and more importantly, understanding how to use data through AI, big data, and data analytics are so important. We told you at our last meeting that we hired our first Chief Data Officer. Namita Pancholi is on the call with us today. I wish she was giving you this presentation, but she put the slide together just highlighting some of the activities that we've just started. We are engaging with the larger community through challenges. We had a summit bringing together healthcare leaders to ask what they saw as the future and what they needed help with. Next two slides, we can keep moving forward, show us data development projects. So developing new data resources at AHRQ, one on social determinants of health, next slide, and another series on synthetic healthcare data. The idea that to protect privacy using very, very new techniques that move data around, that keep the properties of the data set the same, but make none of the data actually real, as a way to allow more people safer access to do better research moving forward. That's in our data development phase. She's also thinking about governance, partnerships, probably other areas that Namita would tell us as well. I just want to make sure you know that that's the way we're thinking. Final slides. Organizational excellence at AHRQ really begins with the staff and making sure they have the resources they need to thrive and bring their best ideas forward and to fruition. We have 4 operating offices at the agency that help us do that. This slide highlights one of them. Mr. Khanna came in and asked how we communicate, and in answering, he said, why are we doing things the way we did in the 2000s? We need to be in the 2020s. And so our Office of Communication has done really amazing work to expand our ability to get the evidence we are generating out to our stakeholders, to healthcare systems, to healthcare professionals, and the public. And this is just a slide highlighting some of the work they're doing in digital communications. Okay, I think that's it. Let's just check. Next slide. Hope it says questions. Yes. That was I hope, a fire hose of information that was slightly useful to the NAC, if not overwhelming. But I'm happy to answer, take a break and answer any questions from NAC members about any of this or anything else. But again, all of this was set up for the 2 discussions we're about to have on AHRQ and COVID-19 and the director's vision of 21st century care.
Great. So thank you, David. Thank you, Gopal and Lucy, for this overview and an update on this important information. I'd like to, before we jump into clarifying questions, Dr. Paul Rosen from CMS is on the call, also with Dr. Ling and Dr. McGann, and also Seth Bitton has joined us online. We are running behind schedule, so I would like to open this up to NAC members, but only for quick clarifying questions. We'll have opportunities to discuss this information a little later in the agenda. So if anyone has any clarifying questions, please let us know now. Otherwise, we will move forward with our next important discussion.
Thank you, Tina. And thank you, David. And do we have the slide covering the COVID-19 up? That's the topic that's been on the forefront in my mind and others' minds as well. So I would like to take a moment to provide an update on the current COVID-19 response efforts happening here at AHRQ and at HHS. As many of you already know, President Trump and Secretary Alex Azar have directed all divisions and agencies within HHS to make COVID-19 response and relief efforts our main priority, while ensuring the health and safety of our staff. So on the operations side, AHRQ has taken major steps to keep the agency running, while at the same time becoming one of the first agencies within the department to move to a full telework arrangement. This policy will remain in place until March 30th, at which time we will reassess where we are as an agency and as a country, and then announce very soon as to the next steps of doing the telework arrangement. Next slide, please. David, if you would please take a moment to provide an update on AHRQ's internal operations, and then I'll come back and with some additional thoughts. David?
Thank you, Gopal. And next slide, if you'd like. I think Gopal already did a good job of explaining to the NAC that our chief priority is the safety and well-being of our staff. And under Gopal's leadership and the leadership of his senior leadership team, not only did we move to telework and made sure people had connections to be able to do that, we've also done a lot of work to help our grantees meet their ongoing challenges, move most of our meetings to virtual like we're doing today. And I would be remiss if I didn't point out that this work is being led specifically by our Associate Director, Ginger McKay-Smith, and our Chief Operating Officer, and Chief Executive Officer, Jay Tobin, who've just done a marvelous job of lowering anxiety by being transparent and giving people great information, both on our operations, our programming, and how to stay safe.
Thank you.
We can advance 2 slides. Thanks. Thank you, Gopal.
Thank you, David. And now we should have a slide up with Bob McNillis who's going to talk about the programmatic focus that we have. So in addition to all the making sure that our staff, who's really extremely important to our program and execution of congressional-mandated agenda, that we also look on the programmatic side as well. And I'm pleased to announce that we have appointed Bob McNillis, a physician assistant, and with expertise in epidemiology, infectious disease, and preventive medicine to lead the agency's response effort. Bob has worked tirelessly over the last few weeks to construct and coordinate AHRQ's response at a departmental level, while leading at the same time an internal strike team here at AHRQ to determine how AHRQ can have both an immediate and long-term impact. I would like to turn over to Bob now to provide an in-depth update on the programmatic work he's doing. Bob, you there?
Yes, I am. Can you hear me okay?
Yes.
Great. Thank you, Director Khanna, and good afternoon, everybody. It's a pleasure to be with you today to talk about AHRQ's response to one of the biggest health care challenges of our age, the coronavirus or COVID-19 pandemic. And first, I need to join Mr. Khanna's acknowledgments at the beginning to thank those of you who are on the front lines, who are seeing patients, who are managing staff, who are working on figuring out supply chains. We so appreciate what you are doing, so thank you for your efforts to keep our country, our nation safe. A personal note first. I began my healthcare career in the mid-'80s, and I still remember the uncertainties and the fear of dealing with HIV in the early days of the epidemic. And while this is a very different epidemic and scarier in so many ways, it is helpful for me anyway to remember that there's always something, whether it was Legionnaire's disease or Lyme's or West Nile or SARS or MERS or H1N1 or H3N2 or influenza, there was always something new to challenge us. And it really highlights for me the importance of AHRQ's work to understand and strengthen the healthcare delivery system, why that is so critical. So thanks. Next slide, please, Jen. So I'd like to talk a little bit about AHRQ's response to the COVID-19 epidemic, but first I want to emphasize that AHRQ is recognized as an important part of the all-of-government response to the pandemic. You'll recall that there's 4 phases to emergency management: preparedness, response, recovery, and then mitigation and prevention. Everyone is focused, and rightly so, on the response phase, as is AHRQ. But we're also looking longer term and thinking about how to address the recovery of the healthcare delivery system after the acute period of the outbreak has passed. We're working closely with partners at HHS, especially at the Assistant Secretary for Preparedness and Response Office, as well as some of you around the room at CDC, at CMS, at HRSA, and others to coordinate our response in the short term, in the intermediate term, and the long term. And we're specifically focused on using AHRQ's competencies. David just described them very nicely around health systems research, around practice improvement, and around data and analytics. Next slide, please. To that end, we have 4 main lines of effort. Sensing the urgency of the coming storm back in mid-February, Director Khanna and David Myers put out an urgent call for ideas from across AHRQ on how we could respond to the epidemic if we received supplemental funds. Those ideas coalesced around 6 concepts that cover the breadth and depth of AHRQ's expertise, and we are poised and ready to go if we have supplemental funds to support them. But meanwhile, another team looked at options for generating new health systems research, either from existing grantees who can pivot and focus on COVID-related work similar to the work that they're doing now, or through solicitation of new external research ideas. And both of those, the pivot and potentially new ideas, are continuing to move forward. Third, within hours of our engaging with the broader HHS response, we received requests for data and analytics to help inform modelers, to guide policymakers and decision makers in responding to the epidemic. That effort has expanded over the past few weeks, and we continue to be an important data partner with HHS and FEMA as these things roll out. And then finally, as Gopal mentioned, we put together a cross-agency response team at AHRQ to complement our other activities, to look across all of AHRQ's assets, to seek gaps and opportunities for our contribution to generate new ideas and to continue to coordinate with HHS and FEMA. So there's a lot going on. It's such a dynamic environment. It's difficult to stay on top of it, but we're doing our best to get ahead of it, think longer term. And before I end, I just need to give kudos to all the staff at AHRQ who have really quickly, willingly, and enthusiastically engaged with it. Not that they have nothing else to do in their day. This all government effort is really critical. So Gopal and David, I'm going to turn it back to you.
Thank you, Bob, and thank you for a spectacular job that you're doing. And then again, I'll echo what Bob just said. Our team has really risen to the occasion and doing just phenomenal work here. This is all stretch effort, and we need it, the country needs it, and we are really proud of you, Bob, and the entire team. I would now like to turn things over to David and to lead a discussion with each of you about AHRQ's efforts and opportunities to expand our impact. Once again, I would urge you to think about how AHRQ can scale our impact, how we should be engaging our stakeholders at all levels, and how you can help individually. So David, please take it from here.
Well, thank you, Gopal. And Tina, please feel free to jump in and help moderate this discussion. This really is the opportunity for you as our national advisors to tell us about what you're seeing, what you're experiencing, what would be the greatest help, and specifically, when possible, think about where are opportunities from AHRQ, given what you've heard about what we do and what we're already doing, to go further, both in the short and immediate term, as well as for slightly longer investments. So,
great. Thank you, David. So we already have some questions coming in. Peter, do you want to start with your first question?
Sure. Can you hear me?
Yes.
Okay, thank you. Yeah, no, first of all, thank you very much for the rapidity with which you guys have organized. I think this is critically important to the country, and really appreciate the efforts and what you all have laid out. My question was really going to build on what you've just discussed, in the sense that I think in addition to some opportunities for what your grantees can do with supplemental funding and the like, to really be very targeted in the near term. A couple of things have come up, at least locally for us, that I think could be beneficial. One is increasingly the ability to have not only capabilities and advanced capabilities for health information exchange, and then data sharing efforts to enable data modeling and better understand how we can not only do some of the prediction people are trying to do now with regard to the immediate surge and the like, but also ongoing changes that are happening in the environment. I think there's going to be a critical role for AHRQ to play in supporting and funding ongoing pragmatic research in rapid cycle to be able to understand how we can better monitor the situation regionally and nationally. So I think, you know, the supplemental funding opportunities that you all are considering, I would applaud and endorse. I think there's another one too, which is perhaps a longer term, you know, to the second question, a slightly longer term benefit. But, you know, for instance, AHRQ currently supports K-12 awardees with learning health system focus. And I think if there was ever a time for pivoting and actually bringing on some learning health system trainees and folks who are going to actually focus in on immediate evaluation of how we need to be learning from all of the real world experiments that are ongoing and being funded by our health systems and by local state government, now is the time. And I think some additional resources to support time for health services researchers and informaticians and others who could rapidly be added to the cadre of people who are learning health system experts would be really, really helpful. So I would also encourage you to consider that when you're thinking about how you use your supplemental funding that hopefully will come soon to pivot for more support for people that are going to focus in on COVID-related learning health and learning community opportunities, because I think it's a real opportunity and a differentiator for AHRQ. So I'll pause there.
Thank you, Peter. Assess Bitten has some question. Assess.
Hi, yeah, this is Astaf Bitan. Thank you for the meeting, and sorry, we obviously can't be there in person. So, you know, I'll just use my question and comment very briefly coming from the primary care perspective. You know, the immediate issues and the immediate needs are obviously in the fields of protective equipment and ventilators, and I think where AHRQ can really play a role in conjunction with other research agencies is really to fund, you know, ongoing pandemic preparedness research. Obviously, this would be in conjunction with CDC, but really on the logistical and supply chain necessities. I mean, even if you take the ventilator shortage, you know, for the most part, people have been quoting statistics that are often 10 years old with 2010 reports, or, you know, decently done but not wonderfully done recent work. So I think that AHRQ can play a role in really providing that information, evidence, and database around logistical preparedness. I think from the perspective of primary care, and I reflect even just having come from a shift this morning, I really do feel, you know, that many practices, especially those affiliated with systems, have really shifted like ours to, you know, 90–95% virtual due to, in part, the lack of protective equipment and negative isolation rooms and other issues. I don't think this is going to be a temporary thing. And David, to your points earlier, I really believe that this will be a nexus point. We'll look back on this and really, it'll catapult certainly primary care, all of ambulatory care, way deeper into the digital and virtual worlds. I think it will go from being, you know, a minor to a major. I think we are all realizing that we can accomplish so much of what we do in primary care, including the important relational parts of primary care, even through virtual and telephonic, and we can save our patients time and right now risk in terms of in-person visits. So I would just really emphasize the opportunity here that we can promote research on these new digital models of ambulatory services and match them with the revamped models of payment that are coming out of MMI and other places, and really in 12 months or 18 months, really set powerful research agendas to reimagine the face of ambulatory care in the U.S. Thank you.
Thank you. That's so important. And I'm going to take the chair's prerogative just to put in my question, because both Peter and Asif have mentioned a common thread, and that's having the data we need to understand the strain on our system and the strain on patients. And so I think AHRQ has a unique opportunity, similarly as they did for the opioid epidemic with their fast track data, able to standardize the way that we're reporting this information across counties, across states, so that we can use this data to better understand our needs and assess our demands that are coming on. So I think there's a huge opportunity for AHRQ in that sense. Okay, so we have a lot of questions coming in. We're going to try and get to everyone's questions. Next, Susan, can you please address your question?
Yes, thank you. I want to underscore what Asaf just mentioned about telehealth and virtual visits, and the CAPS Consortium is actually having a discussion about this in a few days, because we think this is an opportune moment to evaluate from the patient's perspective how the virtual care is working, what helps promote it, what makes it efficient and effective from the patient's perspective, and what we can learn now to make sure, because I really do think this is a tipping point for this across our healthcare system, what we can learn to make it more effective and functional going forward. The other thing I just want to mention quickly is that the Institute for Healthcare Improvement, just in the past couple of days, has set up an international COVID response collaborative, and that collaborative has a whole research section to it. And I think it would be wonderful, given the work that you all are doing around health systems and primary care in pretty much every center at AHRQ, the way that you all could potentially contribute. And if that's something of interest, you have to be invited to join the collaborative, but I can make sure that the right person gets, or the people get the invitation so that you can help contribute to that international work.
Thank you, Susan. We'll take you up on that.
Thanks, David.
Thank you. Yang Ling?
Can you hear me? Can you hear me?
We can.
Yes, we can.
Okay, yes, thank you. And I just want to make a couple of comments. And what I really like to see doing this time, and as a long-term goal, is for AHRQ to work with other agencies to address the testing issues. You know, from what I learned reading all the states about this COVID-19, it's not a short term, and it may last into, you know, whether seasonal or coming back in fall. Everybody's guess, but it seems like we were in a long-term fight with this type of a virus, and the lesson have taught us how about the critical of establish a national surveillance system that we can track, isolate, and so that's how we can win the war. So I wonder if the agency, you know, for short term or long term, to work with NIH and CDC, use our capability of digital resources, personnel, talents, to really help develop a national surveillance system. We have done this for flu. Now we really desperately need this to help for the COVID-19. And another thought I have is that, this COVID-19 really point to everybody is not immune to this type of infection. Young people, elderly people, and the elderly people have a higher death rate so far, but it pointed to also to the people who are in a disadvantage, proportionally disadvantaged, and they are at a higher risk. So I wonder this also whether teaches a lesson to also in the long term help this particular population and try to minimize that or mitigate the risk factors in the long term. Should this, last for 6 months or a year or coming back, and we put out a strategic plan. Thank you.
Thank you. May Pham.
Hi. I had not noticed that anyone on the committee currently comes from private medical practice. So I thought I would try to inject a little bit of that perspective, 1 degree removed. I don't know if people are aware that there is a flood of panic among independent practices at the moment, that they will simply not survive this lockdown and epidemic. And where it intersects with the ongoing conversation thread around telehealth is that, and this is, David, partly a slice of the picture of what I have in mind when I say the business of medicine. I don't mean macroeconomics. I mean on the ground, what happens in day-to-day business decision-making within medicine. That telehealth visits simply do not sustain a practice financially. And that if we envision a future where the ideal care delivery system is far more virtual than it currently is, the entire infrastructure around medical practice will have to adapt and change. That will not happen very quickly or without a lot of pain. And in the meantime, I think that we need to be very aware of and try to find ways to track what happens to access to care of patients who simply cannot optimize the use of digital health services. And all of that brings me, so I'm trying to cram a lot of themes in here, but all of that brings me back to a much broader research opportunity, which is, once upon a time, there were 1 or 2 national ongoing physician surveys, medical practice surveys or surveys of individual physicians. There is no longer. And I think that we're all acutely feeling that. At Anthem, just within the past week, I have had to pass on 3 independent surveys from, relatively small independent organizations trying to figure out what is going on in the field. And that just doesn't feel like a national research infrastructure when we have so many changes in the marketplace. We really, really need to be understanding in much more real time, not just COVID, but all of the ancillary ripple effects after this. I think you're going to see a dramatically changed marketplace after COVID. Independent practices, this was the last thing they needed in terms of another stress. And if you don't think that what happens to independent practices is important to the health of Americans, it's still the majority of Americans get their care from those practices, not from academic medical centers or large health systems. And when those independents disappear, the prices tend to go up for everybody else. So just want us to take a step back and consider what is happening on the ground.
Thank you, May. That's such an important point. Okay, we've got a few more questions here. We're trying to keep on time, so I'm going to move forward. Greg Alexander, do you have a question?
Yes, I do. Can you hear me?
Yes, we can. Thank you.
Hi, thank you very much. My question, or really it's more of a comment. So with COVID and this virus and the way that it's spread and the impact that it's having on the long-term care community is quite devastating for people who are in those communities. For example, one of the many states have adopted the rule that visitors cannot go in to visit long-term care residents. Even hospitals are beginning to limit the amount of visitors that people can have. What this creates, at least in the long-term care community, is greater isolation and and a problem for those people who really still need to have interactions. And I think there's a way for us to be able to think about how telehealth and how health information exchange systems might be able to support and alleviate some of the isolation that's occurring in these facilities and some of the innovation that's being created as a result of the isolation and the patients' families and their interactions and their time together that they want to have. So I encourage you to think about that. I wonder if there's some synergy with PCOR and the funding there that could possibly be used in addition to some of these other funding things that you're thinking about. Thank you.
Thanks, Greg. Great point. Next, move on to Patrick Romano, and it's great to hear from our new NAC members. So, Patrick, do you have a comment or question?
Sure, yeah. Just to quickly build on some of the points that others have made here. So I think that we've seen a very rapid transformation of ambulatory clinical practice into telehealth visits. As Maya's alluded to, this has, of course, financial implications. I'm particularly interested in the implications for quality and safety. Certainly, there's a lot of experience that many aspects of healthcare can be done effectively. Telepsychiatry, for example, has a long history of successful application. But, you know, as we think about essentially eliminating the physical examination from perhaps half or more of all the patient encounters, what are the implications of that? How will that affect diagnostic error or missed diagnoses potentially? How will it affect the safety of care? So these are very important questions, I think, as we go forward, because we're probably not going back to the way things were even a month or two ago. The other set of implications, I think, is related to the workforce. That's also been alluded to. There's been a lot of attention in the media around supply chain issues, but this is, of course, affecting the workforce. There's issues with teamwork. There's issues with burnout. There's issues with how do you rapidly retrain an entire workforce to do things differently. We have a massive healthcare workforce in so many different settings across the country. We've alluded to long-term care, very different from inpatient hospitals, very different from ambulatory practices. And somehow this entire workforce has to be retrained to do things differently, not on a 17-year cycle, but on a 17-hour cycle. So these are incredible challenges, but also, I think, incredible opportunities for AHRQ to contribute to the collective knowledge and discussion going forward.
Thank you, Patrick. And I think what you said is true. You know, we're not looking at something that's going to take 17 years. We're looking at something that can be addressed immediately. And so this is a huge opportunity to get things moving forward, I think, in a timely manner. Thank you for your comment. Next, we'll move on to Andy Masika. Andy, you're muted if you're trying to speak right now. There you go.
Okay. So my question was along the lines of what's been, since we're in crisis mode, relatively underplayed, and it has to do with the impact of this whole event on chronic health, chronic disease, and then the disparity population. So I know AHRQ has databases and a lot of things existing data collection formats. So if there was a way to get more timely information in terms of non-COVID related illnesses, the impact, obviously it's not going to be good, but if we can start to quantify the effect in terms of a short-term priority. So just putting that in the suggestion list for things that our AHRQ might look at. Thank you.
Thanks, Andy. We hear you.
Great. And so we have another question from, we have another question from Yang Ling.
Yes, thank you, Tina. I just thought to add one more that, this COVID-19 crisis really shows us that how so much we lack in the public health system. And it has been short in funding over the years, and the prevalence is just really stunning. So I wonder if the agency would be able to work with other agencies or private sectors to how we can, or other public sectors, how we can improve, rebuild our public health system so that when something like this pandemic happen again, or just even in other crises, that we will be able to take on the challenge and not collapse like this we're seeing. And maybe ask for, if we have money, send out proposals, ask people to do research, how we build a strong public health system. Certainly funding is critical, but how we can build based on the means we have and, to improve the population care in crisis. So that's what I thought to add that. Thank you.
Thank you, Lang Ling. We have a question coming in from Karen.
Thanks, Tina.
Sure.
I wanted to add, I have two comments. The first is I think that COVID, to add to the previous point, will give us also an opportunity to evaluate, there's a natural experiment going on in the different ways that public health is delivered across the country, and give us an opportunity to actually do an evaluation of public health delivery models. And so I would just add that to the potential for consideration to AHRQ's agenda. I might also add that an additional area of providers that we've intermittently touched on, but maybe an area that AHRQ would like to spend more time quantifying, are community-based organizations that all of us in healthcare depend on for meeting the social needs of our patients. Those are going to undergo a considerable stress, and we're probably going to see some changes in that delivery system as well, and that may be another area that would be a good one for inquiry. Thank you.
Thank you. And I think I'm gonna add my own comment here. One of the things I think that's going to be really important is we have all of these different states that are implementing different strategies for containing COVID-19, for sheltering strategies, reduction of social distancing. And so I think there's an important opportunity here for AHRQ to look at the bigger picture and synthesize that evidence to really understand, what are some of the systematic strategies being implemented that are really taking, having an effect, and what are those effects, and how can we learn from that for future outbreaks or epidemics. So with that, it is about 10:55 my time, so it must be 1:55 your time. So we're going to take a short break. We're going to take a 10-minute break. We'll reconvene in 10 minutes, so at 2:05, and then we'll move on to our next talk discussion, which is going to be on the 21st Century Care Act. So we'll take a pause, everyone, for 10 minutes, and we'll see you back here shortly. Thank you. A break. We are going to move forward on our agenda. I would like to turn it over now to Gopal Khanna and David Myers. We're going to have another very interesting conversation right now on 21st Century Cares Act. So I will turn it over to you.
Thank you, Tina. Thank you so much, and thank you, David, for the earlier discussion and the NAC colleagues. I appreciate your input and your thoughts and ideas. We have made a note of them. And of course, this conversation will continue. I wish we had more time to talk about COVID-19, which is really right in our minds all the time right now. But let me for a moment also at this point move our discussion on this afternoon to a topic that's extremely important and near dear to my heart, which is a long-term topic, and topic is about AHRQ's 21st Century Care initiatives, our approach to 21st century care, and what we think about it. Could you please bring up the quadrant slide? Some of you may have already seen this, but basically what I'm trying to say over here is that time has come that we need to rethink and reimagine as to, given the current realities, as to how we should be looking and have a greater impact. And yes, we are a small agency, but we've had a mighty big impact. Our research on healthcare delivery aims to improve the lives of the roughly 275. That is really the primary federal agency tasked with making sure that $2.5 trillion Americans spend on healthcare delivery each year pays for care that is safe, high quality, and high value. We see cure and care as two sides of the same coin. While science and research is needed for new discoveries, and but science and research and new ways of improving practices, evidence-based practice, are an imperative. We are committed to helping HHS and Secretary Azar deliver on the administration vision for a healthcare system that puts patients in control, provides peace of mind, and treats patients like human beings and not a number. In particular, Secretary Azar has challenged all of us in HHS to deliver on that vision through three cross-cutting platforms: reforming the financing of care, deriving better value from that care, and tackling specific health challenges. I'm happy to say that AHRQ is helping and is at the forefront in making a difference in all three areas. For instance, as a nation, we devote tremendous resources to discovering and developing new treatments. In 2016, Congress passed the 21st Century finding new tools and billions of dollars to agencies like the FDA and NIH to help accelerate medical innovation. We have failed to recognize the importance of investing in 21st century care. Best medicines and therapies in the world are useless if they aren't delivered to the right patient by the right clinician at the right time in the right setting. You see, a cure for cancer means nothing if while receiving it, a patient dies of an infection they acquired from the hospital. Our healthcare system is broken. Major work needs to be done in order to fix it. Each year, 12 million people are affected by diagnostic error, 4 million of which lead to serious health consequences, including premature death. With multiple chronic conditions bounce from doctor to doctor for treatment after treatment, and at the end of the day find themselves no better off than where they started. Americans are frustrated by healthcare system, and rightfully so. That's why we have made it our mission to lead the change and charge in starting a new conversation, one that's centered on fundamentally changing the way healthcare is delivered in the United States, not only to help deliver on Secretary Azar's and administration's priorities, but to make a difference in the healthcare services that patients receive. Doing so will require tremendous and increased effort. But we are the only agency with the mission and expertise to undertake that task. Each of you is here today because you recognize the important work we do. Today, we are asking you to join us in our pursuit of the new frontier. Our staff has been working hard to define what we see as the way ahead in achieving 21st century care. We're eager to hear your thoughts. Once again, I would urge you to think about and inform us as to how AHRQ can scale its operations Who are the critical stakeholders? And how, most importantly, how can you help us amplify our work? At this point, I'd like to turn over to David once again for a deeper dive into AHRQ's vision for 21st century care. Again, this is an area we need to think about while we are addressing the COVID-19 crisis now. David, please take it from here.
Thank you so much, Gopal. I need to make a note to myself never to follow a visionary in leading a discussion. That was really amazing. If we go to the next slide, well, actually, go back. Sorry, don't show this yet. Thank you. To the NAC members, Gopal mentioned 21st Century CARES Act, and that was published or passed into law about the 21st Century CARES Act, about 5 years ago. It was a bipartisan act investing approximately $5 billion in developing 21st century cures. And so investing in NIH and FDA, as Gopal said, to transform how they delivered care, did their research, and give them the resources necessary to make breakthroughs. A little bit of money also went into interoperability as well, and a few other projects. The Congress, before COVID-19 came onto our horizon, started asking the question, is it time to think, now that it's been 5 years, about another round, about thinking of what they initially called Cures 2.0. And we sent around in advance of this meeting a letter that was published to the American people by two congressional representatives, DeJet and Upton, where they asked for feedback from the nation on if America were to do a Cures 2.0, what should it include? And in their letter, they outlined 3 or 4 areas that they thought were important, including advancing digital health to improve patient experience and access to care, focusing on the needs of caregivers and the important role they play in delivering care. When we read the statement at AHRQ, we recognized that they weren't really talking about a Cures 2.0. They were talking about what we call 21st century care, and that aligned, as you just heard, with Director Khanna's vision. So next slide. We organized their thinking and the different areas that they put together with our thinking about what the U.S. needed to invest in to deliver to develop a 21st century care system capable of delivering high quality, safe, high value care to all Americans. And here are the 6 domains on the slide that just in our preliminary thinking, we bucketed as important areas for focus. Digital health and data, very similar to something that DeJet and Upton had in theirs, expanding it a little bit, recognizing the need not just for the delivery of care, but the collection of information to advance research, understanding, and measurement. Healthy economics, the application of behavioral economics, of business, as well as new funding mechanisms to incentivize the kind of care delivery we thought was necessary. Real-world evidence for care, the ability to, and each of these has multiple potential things on it, but real-world evidence for care really struck our ideas of that decreasing the 17-year gap, in fact, not completely vaporizing that gap, and how does evidence easily become incorporated at the point of care as healthcare's decision makers, both professionals and patients and families, both get access to information that helps them make informed decisions based on their own values. Care for the whole person, the defragmentation, instead of a disease-focused system, a person-centered system, many things fall under that. Safe care, clearly building on AHRQ's work and the nation's work, but continuing that and not letting that fall behind. And this being the anniversary of Terror is Human, continuing that movement forward and investing in that. And AHRQ's commitment to understanding that the healthcare delivery system could be strengthened if it had a stronger foundation with real-world evidence and care for the whole person, based in a primary care system, but that primary care system might look different than the one we currently have now. Those were the 6 areas we started with, and we'd like to have a discussion with the NAC. This may be the first time you've thought about this, and it is definitely going to be the first time we've thought about this at AHRQ in a post-COVID world, or a current and post-COVID world. But are these the right 6 areas? Are there topics that you think are important that could be included in these larger domains? Are there topics that you think are important that are not going to fit in and we need a 7th or 8th domain, or the country should? Are there areas here that you look at and say, that shouldn't be a focus of a 21st century care program at AHRQ or for the nation? We'd like your feedback on that. But I'll close before we turn over to questions to say that we also see this as an opportunity potentially if a legislative vehicle, as DeJet and Upton suggested they wanted to do, if they put that forward, this would be an opportunity focusing on 21st century care to reauthorize the Agency for Healthcare Research and Quality as an independent agency. We exist year to year because of the fact that if Congress appropriates money, an agency or an organization in the federal government that whose authorization has gone away is automatically reauthorized for the next year. Our authorization actually ran out in 2005. So this is an opportunity as we rethink about what the nation's healthcare system needs to rethink about AHRQ and use this as a vehicle for reauthorizing AHRQ. Interestingly, NIH's authorization had also elapsed, and the 21st Century Cures Act was used to reauthorize NIH for 10 more years as well. With that said, we can flip to the next slide, though I think we'll come back to this one in a moment. But here are some questions that we would like the NAC to answer. And you do not, in this discussion, need to frame yourself as questions. If you do have a question for us, that's great. But we really want your comments on this. We want your advice as our National Advisory Committee. Where do you think are the highest areas of impact if there were new investments improving care delivery? Where can AHRQ specifically have the greatest impact? We do recognize that this large an effort brings in our federal partners in CDC, in HRSA, in other places as well. We don't expect that we will do all of the things that this act could move forward. What are the greatest challenges from your perspective that your organizations and your members are having will have over the next 10 years related to the delivery of care? And are there other initiatives that we should be aware of and groups that we should be partnering with when we think about 21st century care? So, Tina, I'm going to turn it back to you to moderate the flow of discussion, and you can decide, do you want to leave these questions up, or do you want to go back and let people see the 6 domains?
Thank you, David. I think this is such an important topic, and I'm looking forward to hearing comments from our NAC members. Why don't we leave these questions up to start our discussion? And really, you know, from our NAC members, when you're thinking about these questions and thinking about the 6 components, you know, what are the gaps that we see in healthcare delivery that AHRQ can help fill with the Cures Act? So we will open it up to the floor for questions. We have some questions coming in. We'll start with Mai, but I also would like to call on Dr. Raju next and Kathy Bradley. So, but we'll start with Mai, please.
Hi, thanks. I have a cross-cutting question, David, because it could be that the framework for the current domains embeds the assumption that machine learning can be an element in any or all of them, which is true. But I wonder if that is something that is worth calling out, because at the moment, it feels like there is no kind of broad, again, national enterprise for considering issues related to machine learning from a safety, disparities, quality, cost effectiveness, all of those perspectives. And so what the field is left with is trying to navigate through a lot of hype. And it just feels like a broad cross-cutting theme that AHRQ seems poised to take leadership on. I'd love your thoughts on that.
No, thanks, Maya, and that is a great point, and we'll try to bring it out more. Could we flip back one slide, Jen? I think we were putting artificial intelligence and machine learning into our idea of digital health and data. That was the bucket where we would have seen that type of work. But if it's, we can either think of renaming it, or I think in future iterations, one could imagine these would have sub-things that call out those critical issues. But we are fully with you that machine learning and how it is going to change provider-patient interactions, how it's going to healthcare decision-making, the business of healthcare. There are multiple levels where machine learning and artificial intelligence have the potential to help or potentially cause unanticipated problems.
Great, thanks, David. Dr. Raju, do you have any comments or opinions, questions you would like to add to this conversation? I think you have some great experience we can learn from. Maybe he's still on break. Kathy.
Yes.
Hi, there's Dr. Raju. Sorry, Kathy, we'll get right back to you.
Okay.
Sure, okay.
Go ahead, Raju. Dr. Raju, can you, I can't hear you. Did you have a comment?
Can you hear me? You can hear me now?
Yes, we can hear you.
Okay, perfect. No, I think AHRQ's, overall direction has been extremely good. They're all doing the right things and identifying the right issues as we go along. And I've been watching and hearing the comments from my colleagues regarding stabilization and strengthening of primary care. And one of the issues we struggle with, in the care aspect of it is we are living in a highly competitive, in certain parts of the geography, we are in an extremely competitive environment where the hospitals are really competing with each other for high-end services and also for specialty hospital systems. So to a great extent, there is a tendency in the hospital side to really look for profitable service lines, and how do you give that in a way that it attracts the market. So that is something in reality. It's though most of the hospitals are not for profit, they still have to have a margin, and that is one issue probably we have to be a little more cognizant of as we are moving there. That's one of the reasons why some of the primary care issues are not really coming to the forefront. The second issue is that, one thing we learned from this pandemic, or continue to learn from it, is the fact that we really need to understand how to increase the capacity of the hospital beds quickly, go up and down, and that should be something which has got to be practiced and also has to be there, because it may not be corona next year, it could be some form of a natural disaster. And the third part is that my colleagues talked about a few minutes ago, is we need to understand how to deliver care for more people with less providers. That could be a virtual care, telemedicine, artificial intelligence, whatever the technology is. We may be asked to provide care for a large number of people, but very few providers. And we have really not learned that art of doing that in a very effective way. Thank you.
Thank you so much. Yeah, go ahead, David, sorry.
Nope, I was just saying thanks. That's all. Great points.
Perfect. Kathy.
Yes, thank you. So I had 2 points. I think first there's an opportunity exists for a data science infrastructure, and there's currently a fragmented system consisting of bioinformatics, electronic medical records, and to a lesser extent, some population-based type systems, and AHRQ can be creative in supporting the development and integration of these various systems to create a greater data science architecture. Bringing these together and setting a vision for how these systems can be integrated in health systems as well as private practices would be greatly beneficial to healthcare delivery. And then I think a second part of that is the intersection of dissemination, implementation, research, and health economics. And this is an area where AHRQ has already been a leader in this area of research and aiding healthcare delivery. I think that as we develop the data science systems that need to be in place, AHRQ has an opportunity for a big role in the dissemination and implementation, along with using the health economics tools, so that these data science architectures aren't limited to just academic medical centers, that they can be used in private practices, either to tap into them or have a reasonable way to implement those kind of systems for themselves.
Thanks, Kathy. Okay, we have comments coming in. Greg, do you have a comment or question?
Yeah, I just have a comment. Thank you very much. Great discussion. What I want to say is that all 6 of these areas are great areas. I don't think I really have anything to add. They're very broad in scope and could really take in all sorts of different kinds of questions to address gaps that are existing. One thing that I am concerned about, though, is that as you begin to develop your research trajectories for these 6 areas, that you consider where the healthcare system is in respect to different areas. So, for example, in digital health and data, acute care, physician practices, they're much farther advanced in the use of digital health and data than other settings like long-term care. Even home care is probably much more advanced than the long-term care setting like nursing homes or assisted living. So applying really intense machine learning and different types of artificial intelligence to those environments, they're just on the beginning stages of that kind of innovation and how to adapt it. And so I think what you'll find is that there is going to be quite a bit of disparity between settings based on some of these questions, and the research questions need to be able to address that disparity and also to lift up those, to propose research and to encourage research that really lifts the bottom line of those individuals that are sort of on the lower end of that disparity spectrum. I'll stop there. Thank you.
Thanks, Greg.
Observations.
Absolutely. I know Peter has a question, comment. Sorry, comment. Peter, please.
Yes, thank you. I would agree with what's been said. I think the last couple of comments covered a fair bit of what I was going to say. So the only other thing I would emphasize and maybe focus on as I look through the list is that even though it could be considered embedded in some of these, I wouldn't want AHRQ to lose the focus on the learning health system elements of what I believe you all have done so much excellent work in and are such leaders in. I don't think there's really any other group that is owning that as well, and I think it's a critical piece to this future care, 21st century care vision. So the learning health system element is the one that I would make sure and highlight and not lose. And I agree with otherwise the comments that were made, particularly by Kathy recently about the implementation science and informatics elements. That was my additional comment, though.
Very helpful. Thanks.
Thank you. Chris. Chris Goschel, do you have a comment?
I do. Thank you.
Thanks.
I wanted to just make certain, Greg talked about long-term care, home care. I'm thinking community care and wanting to make sure in this list, which gets at really important areas of research, that we don't lose the high-touch component of care delivery as we work diligently toward, I'm going to say, more digital platforms and artificial intelligence, machine learning. At the end of the day, that human connection is a really important aspect where AHRQ research has been instrumental in helping us deliver messages that touch the hearts of the patients we serve and allow them to take the actions that we know evidence says offer them best hope of improvement in their clinical condition. So I see safe care and primary care, don't want to lose the continuum or the notion of, I'm going to say, high touch in community care.
Thanks, Chris. This is David. And if we add the larger one, care for the whole person, I think its first thing was about that relationship-based, person-centered, high, emotionally resonant care. We'll bring that out, and absolutely that needs to be brought across the entire spectrum. And when we do that, I'm going to call you to be the spokesperson for that area. Thank you.
Great. Thank you, Chris. Karen.
Thanks, Tina. I wanted to add a perspective about in the digital health and data area related, and actually it's a theme that cross-cuts, which is related to the ability of us to scale care and to have individual providers take care of more patients. That's going to require, obviously, team-based care, but there's a human factors and knowledge management aspect to that that likely deserves some evaluation of what are the most appropriate and effective, high quality and safe ways for the team to be communicating so that they can actually have that, provide that continuous and care across the continuum. Thank you.
So I heard both human factors and team-based. Excellent. Thank you.
Gretchen. Gretchen, do you have a comment?
Yeah, hi. Can you hear me all right?
Yes.
Sorry, I got bounced out. I'm just getting myself back in here. I had a comment on the those 6 areas, and there are a couple of areas that I think could be worthwhile. One is behavioral health, which is cross-cutting because you could say, what's the real-world evidence? What about care for the whole person? What about safe care in that field? I'm not sure we should dump it all on primary care. There are also some economic dimensions of that. And I would like to see that in kind of the next wave of our thinking. Another one is under the data pillar, to really emphasize in the next go-round the issue of affordability and the cost dimension, which we've never been able to tackle very well, and both affordability and access in general, and especially access to primary care and mental health. And then the last comment I thought might be useful for chewing on a little bit is if you no longer could serve the healthcare system, it wasn't your choice, you couldn't do it for whatever reason, and you had to look through everything through a consumer lens, how would that change your work? Because there's almost nobody that really has as its mission to champion the consumer. And so I thought maybe AHRQ is probably the closest. You know, we got MEPS data and you got a lot of stuff. And I'm not suggesting we abandon the whole approach with the provider systems and healthcare systems, but it would be useful to just try to shift thinking a little bit to say what more could we do if we could only think of our consumer as the end beneficiary here. Okay, that's my thoughts.
So thank you, Chris. That's what we depend on the NAC to do, to push us to ask important, difficult questions. So we will do that. Thank you.
Great. Thanks. I would like to call on Edmondo. This is, you know, I would like to hear from you on your expertise. A lot of this conversation has been around digital health and data, and I think you have a lot to contribute to this conversation. Do you have any comments regarding the list we have there, or anything else?
Yeah. So, can you hear me? No? Oh, okay. Sorry, I'm having a little trouble on my internet connection, so apologies. Things are popping in and out for me. No, I think most of the things have been said. I wanted to call out the perspective of the patient, and that which has been mentioned as well. Which, you know, we talked about essentially what I would describe as a digital divide that we're potentially setting up between, say, those folks like who are managing long-term care and some of these other places versus maybe acute care. But there's going to be potentially a digital divide across patients as well. We're seeing that already as we shift a lot of our care to virtual. I mean, we shifted virtual visits tenfold in a matter of 2 days. And so we really have to, I think, looking at how we're interacting. When we're talking about care here, we're talking about 21st century care. We got to look at the perspective of the patient. What are the social determinants? And also, are we designing our digital interventions for patients in a way that actually cuts across all different socioeconomic and other criteria? We really have to be thinking about how we're designing those interventions, how we're designing those interactions, so that we actually aren't exacerbating our challenges with disparities that we have now. We have an opportunity with digital health to truly address this. Be very careful, because we could also exactly. I really want to pay attention to that part of this.
Great. Yeah, that's so important. I think the digital divide is something we really need to keep in mind. David, did you have any comments you would like to add to that?
Thank you, Dina. No, those are, again, the kind of things we want to hear. And I've heard from some folks already listening to your comments that what I want to take to be, so correct me if I'm wrong, that you think we're on the right track. This is a good, you know, you're willing to endorse Gopal's vision and would like to see us continue to flesh this out and build it more. Can we go to the next slide? And we're taking everything you said. You know, we'd like to do that. This last question, though, are there other things that we should know about and be aligning with to do this? And then I want to also echo something Gopal told us at the beginning. He really sees the job of the NAC as twofold, helping us understand what the field needs, advising AHRQ and the AHRQ director on where are the most important opportunities to have the greatest impact. But then on the flip side of that, as ambassadors for AHRQ and helping us build the external coalitions that are necessary to make this work happen. And so if you have thoughts about, and you don't have to speak up about it today, but we hope to hear from you, you know, when you recognize, wait, here's something I could do as a NAC member to make this vision more possible. So I'll plant that one for you all in the future, but in the immediate, are there things that are happening that you think we should know about, align with, partner with? I've heard some of those, but that I don't know if we've touched on that specifically.
Great. We have some questions. Okay, we're going back to a few comments here. And so please keep David's comments in mind. I'm going to circle back to Peter, had another comment he wanted to add.
Yeah, thank you. I'll keep it brief, but I think even following up on David's question and the last question there, I just wanted to maybe emphasize further, I think it was Karen's statement and comment about knowledge management. I think it could be relevant. So there's a lot of focus, obviously, on data and fair data principles and the like, and I agree with what's been said, but while there are many other groups that are working on that, I think it would be particularly useful for AHRQ to focus in on knowledge and the mobilization of knowledge objects and knowledge capabilities, and in that regard, there is some nascent activity happening in the area of mobilizing computable knowledge. And this, again, is an area that builds on great strengths in history at AHRQ. So I think as part of the overall agenda and a way to sort of demonstrate complementarity to a lot of the other work that's happening in the data sciences as it relates to healthcare science and health disciplines, AHRQ's advancement of knowledge as a resource could be a unique contribution that I don't think others are doing as much, and it could connect to some other initiatives that advance learning health system activities. So I wanted to add that to the discussion.
Thank you, Peter. It's an important point. We've got 2 more comments we're going to get to right now, so we'll move on to Yan-Ling. Do you have a brief comment?
Yeah, thank you, Tina. Very brief. Along the line, those are 6 items about 21st century and also safe care. And I just thought, maybe we should also really put efforts in the patient report outcome. And I know there's a lot of, that it has been drawn lots of attention in healthcare, and there are people developing those type of reporting systems. But I think it would be really nice to have a collaborative efforts from agencies and whoever's working down there, because patients' voice and can be heard, and also when they experience some symptom, sometimes being ignored, but they can be a tremendous resources for diagnosis. So I would like to have see something happen that a patient report outcome can be incorporated into the system to reduce diagnostic error. Thank you.
Terrific. Terrific point. Thank you.
Yeah, great point. Susan, did you have a comment you would like to add? Susan, oh, yeah.
Can you hear me?
Yes.
Okay. I think that we have a lot of opportunities working with the CAPS databases to understand how we can address issues around patient safety, patient engagement in a much more comprehensive and effective way. So just as one example, we have data that shows that hospitals that decrease or improve the way that they perform on the HCAPS question about responsiveness of staff have fewer falls in the hospital setting. I also have just recently seen a paper that is out for publication that found that with respect to failure to diagnose in the emergency department, they use the CAPS communication items and found that people that reported lower scores on communication in the emergency department had higher incidences of failure to diagnose. So I think there's a lot of data and a lot of ways that we can be analyzing existing AHRQ databases that will help us understand better how to improve safety, failure to diagnose, and other issues around safe care and improving outcomes. In terms of another initiative that I think it would be very interesting to think about how AHRQ could be a partner is there is now an international, actually it's a worldwide movement around what matters to you, which is really about engaging with our staff about what matters to them in their delivery of care and what matters to our patients and families. And there are several different countries that are participating in this, and there's a huge international work group working on how to not just make this a day, but how to hardwire this into our healthcare systems. And there's a tremendous amount of interest that I think very much fits in with the work going on with the committee that Jeff Brady's co-chairing, the National Steering Committee on Patient Safety and the patient engagement work there, as well as many other settings. There's a lot of interest in studying what are the different ways that we can engage with patients and our staff to understand what are the most effective interventions that really make a difference around what matters to them and how we improve overall quality. And I can certainly connect you with that work as well. And actually, if you just Google what matters to you day, it will pop up all the resources internationally and all the work that's happening in that arena.
Thank you. Okay, well, SF, did you have an additional comment you could provide?
Yeah, just a very brief comment, just in reflecting on what has been said. You know, I think that in this COVID and post-COVID era and reflecting on the priorities that you've laid out for AHRQ, there really is a necessity to be able to not only dig into the specific and into the channels of work, but really for AHRQ to be able to be an agency that promotes research that is systemic, that looks at the whole as opposed to just small parts, and really that takes risks, that is bold, that doesn't just support the research lines of interest that have previously generated nice, safe bets and good, safe papers, but rather research that is more implementation in focus, that is more risky, that might even fail, because I think that in this new era, sort of playing the safe card and just moving with the usual suspects is just not going to be enough. So I just really encourage the committee and the leadership to take big bets, to take risks, to not be afraid to fail, and to not sort of default to sometimes the academic safe zones of incremental research, but rather to be bold and look at things holistically and systemically.
Thank you for that comment.
Yeah, I'd love to accept that challenge, Asaf. Thank you for it.
Great. We have another comment from Kathy Bradley.
Yes, just going back to the points about data science and knowledge management, there are a lot of data available, but no one seems to have taken on the role of setting the vision for how it can be used in an efficient way. And these data systems are overwhelmingly vast, but I think don't answer the day-to-day questions of healthcare delivery just yet, because no one has wrangled them down and put them in a concise way and to say, here's the vision for how we see these data systems fitting into healthcare delivery. And I think that's a huge opportunity for AHRQ to set that vision, test different approaches, and measure outcomes.
Thank you, Kathy. So thank you all for your comments and questions. Thank you all for your comments and questions. I'd like to remind NAC members to text Jamie if you have any additional comments. And Jamie, and we're now going to move into the public comment agenda. So I'm going to ask NAC members if you have any final, again, comments or suggestions or topics for future meetings, please text that to Jamie. Or if any member would like to share any additional thoughts or comments, also please feel free to reach out to Gopal directly or Jamie. So now we'll move to the public comment section. And so thank you for your questions. And our first comment is coming from Dr. Knighton from Case Western Reserve University.
Provoking conversation. So I wanted to mention that I saw a post recently by AHRQ on Twitter, and a powerful message was emphasizing that we are all patients. We are all patients and partners and recipients in care. And as we think about how do we get information from the real world and in real world settings, I just want to express my journey of even becoming a scientist was rooted in my experience as a bedside nurse during the time of H1N1 and even Ebola. I remember caring for patients, being fearful that I could become sick and compromised by caring for them. And what that brought up to me was that, wow, our hand hygiene is emphasized as well as the environment is emphasized for being clean. And we talk about keeping our patients safe. The one thing that we tend to neglect is the patient's role in infection prevention and their role in hand hygiene. In Cleveland, prior to us having an outbreak for COVID-19, I was conducting a study and was looking at our emergency departments. And the fact that even though we as providers are aware of healthcare-associated infections, patients aren't aware of healthcare-associated infections because they don't often come in contact with our healthcare system. Secondly, the other thing is because they don't come in contact with our healthcare system as often, the ways in which that we're providing education may not necessarily be adequate for them to understand their role. Something, for example, that struck me in my research is that patients don't feel comfortable using the materials in the hospital because they believe that they are for staff. So there's been such an emphasis on healthcare staff that patients don't tend to clean their hands. I also ask that we look back at what I would consider to be the low-hanging fruit of even looking at the opioid epidemic. The fact that our patients, considering older adults, when they go and get a prescription change, no one is collecting their old medication. So that medication is still sitting in their medicine cabinets just like it is for some of us. So it's these issues that I ask that when we look and we say, okay, well, what's going on? How can we create an infrastructure or data systems that will allow us to tell a story, whether that's an aggregate of things from multiple providers that is saying, okay, well, this is the problem that I'm encountering in my healthcare setting, and how do we fix it? And then, too, for something as simple as patient hand hygiene, we know that hand hygiene works universally, as we are oftentimes emphasizing this even right now, but it's still that one thing that continues to need evidence based off of our current infrastructure. So how do we move things very swiftly from being able to determine things into practical settings when we are in times like these under stress? So I just want to say thank you. I greatly appreciate the emphasis that you put on HAIs, patient safety, self-management, older adults, and a lot of the other areas that need attention that sometimes I don't feel is reflected and in the other funding announcements are being done as focused as other agencies. And so I know I'm all over the place, but even going back to the opioids and thinking about teaming up with other agencies, how does the DEA do their drug take-back days, and how does that contribute to patients that may have these extra medications? If a patient is prescribed metoprolol today for 5 milligrams and that prescription changes to 10, or it's lessened, who is taking that medication back out of that patient's cabinet to make sure that they're not incorrectly taking them? So I just encourage you all to take a step back, look at maybe what's happening in your lives to your loved ones, and say to yourself, is there a moment in care that was missed, and is there something there that needs to be emphasized that maybe could be driving the systemic changes and problems that we're having? Thank you.
Thank you for your question. We have another question coming from Christy Egg, who is a nurse, public health student, non-voting member of IAPMO, and part of the Legionella Task Force 2024. Christy, please.
Hi, Dr. Boussard, I hope you can hear me.
Yes, we can.
Wonderful. I'm grateful for the comment made earlier. I think it was by David that we should be reaching out and risk-taking in our research, because the comment that I have to make is a bit risky. Basically what it is that I'm part of the IAPMO, which is the International Association on plumbing and mechanical organization, and so basically they write codes for things. And one of the things that I'm focused on as a public health student and as a registered nurse is Legionella. And what I had started to notice was that what I'm wondering is, has there been any research done to see if there is a crossover or an association between the COVID-19 patients and healthcare-associated Legionnaires' disease? The reason I ask is because there's a substantial rise in the patients in New York, the number of cases doubling every 2 to 3 days in the Long Island area and in New York City, of course, which is also happens to be the center of the most recent and largest outbreaks of cooling tower contaminated with Legionella, Legionella pneumophila, serotype 1. Now, why I'm asking this is because most hospitals, because of their size, are cooled by cooling towers. So if you have patients going in with moderate signs of the COVID-19, and of course the cooling towers are already infected with the Legionella pneumophila, and it gets back into the system, which is not uncommon, then there could be a cross-contamination here. And what we could be seeing is not necessarily just the COVID-19 virus, but these people that are already immunocompromised because they have a virus, then you have the bacteria on top of it. Are they testing people? Could it be done? Is this research that is worth doing? There's a urine test that can be done to test for Legionnaires, and then unfortunately those who've already succumbed to COVID-19, looking at lung tissue to see if the Legionella bacteria is present. I'm just wondering if there's a way to look and test the water towers, test the cooling towers. This is risky research, but it's research that might well be worth it if we could somehow find a way to help flatten the curve.
Thank you for your question. Yes, it is very important. We have another question, public comment coming in, and this is going to be read by Jamie. So I'm going to turn it over to Jamie.
Can everybody hear me?
Yes.
Okay, great. This is a comment from Dr. Lucy Savitz. She's at the Kaiser Permanente Northwest Center for Health Research. She writes, after 9/11, AHRQ funded a portfolio of projects aimed at bioterrorism emergency preparedness. Results from that work later informed local, state, federal response following Hurricane Katrina. Now, findings are informing today's response to COVID-19. That original funding came through task orders using the Integrated Delivery System Research Network, now known as ACTION. Is AHRQ planning to make the Action 4 awards and use the rapid cycle research mechanism to support learning healthcare system capture lessons learned, development and implementation and spread of targeted tools, and understand the impact of health outcomes in general and specific to COVID-19?
Thank you, Jamie. So I would like to thank everyone for their questions. AHRQ will be thinking about these questions and following up if needed to anyone who has provided questions. With that, we want to start wrapping up our meeting. Our agenda. I would like to first ask
Oh, sorry, can you hear me? This is David at AHRQ.
Oh, yes, David.
This is a late-breaking announcement, and I'm sorry to jump in like this, but I'm so excited to be able to tell our NAC, for you all to be the first folks to hear this. During the NAC meeting in the last half hour, AHRQ just published 2 notice of intents which is our way of signaling to the health services research community our intention to post new funding announcements. And the first one of them, I'm just going to read the titles, and we will send you and follow up the links, and we hope you will read these and share them widely. But just to understand, to follow up on our discussion of COVID-19, the first is Notice of Intent, revision supplements to existing AHRQ grants and cooperative agreements to address health system responsiveness to COVID-19. So in an attempt recognizing that grantees currently in the field have the potential to learn a lot what's happening right now and expand what their original research in safety or quality or primary care or telehealth to help us answer questions and get funds into the field as fast as possible. And the second is called the Notice of Intent, new funding opportunity announcements to support novel, high-impact studies evaluating health system and healthcare personnel responses to COVID-19. And that one specifically calls out telehealth, primary care, and system-level changes and evaluating the future of healthcare after COVID-19. Now, neither of these are available yet. The funding announcements will follow, but we are working as hard as we can, and your discussion today will impact how we write these actual funding announcements. So thank you so much. Sorry, back to you, Tina. Oh, and thank you enormously to the entire team at AHRQ who pulled together to make this happen. Thank you.
Thank you, David. That's an amazing opportunity, and thank you for sharing that with us. It's so nice to see AHRQ moving so quickly and producing these opportunities so rapidly. In closing, I would like to go around to our NAC members, and I want you to think about how we can help AHRQ disseminate their message to stakeholders, information about their important mission. And I want you to, to know how this is so important that AHRQ can amplify this message. So in closing, I would like to go around briefly and have you make just a brief comment, 30 seconds maybe, about how you think you can help AHRQ disseminate their message to and educate other stakeholders about their mission. We'll go through our list, and again, just a brief comment. We'll start with Greg.
Thank you. The perils of being an A in the alphabet.
Right. Sorry, Greg.
Okay. All right. So quite honestly, I think in the research world, I think that people are looking for opportunities to enhance their research, their existing research, and I'm one of those individuals who has an R01 from AHRQ and who is like wanting to, has questions but need the mechanism to do that in order to respond to this crisis that we're in. So I'll share those, and I believe that they will be valuable pieces of information for a lot of researchers that I know that use AHRQ as their main source. And I think that will drive better dissemination and better questions about the problems we're having. Thank you.
Thank you, Greg. Karen, can you help us think about how we can disseminate information, speeches, stakeholders, et cetera, and get AHRQ's message out? We might have lost Karen. I'll move on. Oh, there you are. Hi.
No, did you mean Kathy? Or
no, I was looking at Karen. Kathy, go ahead. Go ahead, Kathy.
No. I mean, she may be, whoever's next in the alphabet. I wasn't sure.
Yeah, we were Karen. I'm going to move on to SF.
Yeah, very briefly, I would just say, taking big bets on funding initiatives around the science of scale, what it takes not just to run good research projects and show success at a pilot level or 1 or 2 institution level, but rather taking big bets behind a multiplicity of implementation arms of the research to really build out that scale science that we need. I think making some big bets in those areas will really help to get AHRQ's message out.
Thank you. Kathy.
So sometimes I worry that AHRQ operates more independently than the other agencies in the NIH and CDC, and I think to get the message out, one way would be through partnerships with these other agencies that's doing a lot of things as well, and to see how you can be more part of that messaging.
Great. Thank you, Kathy. Gretchen.
You know, I think that you can get messages out through the mass media if it has a direct connection to the consumer. So that might be just a communication strategy that could have some potential.
Great. Thank you. Susan, any thoughts? Susan, you're still on mute if you're trying to speak.
Am I still on mute?
No, you're fine. There you go, Susan.
Yeah, I do have a lot of thoughts about this, but I need to think about them a little bit more.
Great, great. Please, you know, AHRQ, contact Jamie or Gopal or AHRQ directly, and they would love to receive your comments or information.
I will.
Perfect. Thank you, Susan. Peter, you know, how can you leverage your position in other areas to disseminate this message? I think you have a broad reach. I would love to hear your thoughts on this. Oh, we might have lost Peter. Yes, it looks like Peter's no longer online. Christine.
Great. A couple of things very quickly. I'm faculty at Georgetown, so I certainly can disseminate and will push more of this information out across the university setting. Also, MedStar Health has a huge research institute, and we have scientists studying everything from machine learning and artificial intelligence and human factors to healthcare delivery research, et cetera. And so disseminating through that network is something I will push. I think something else, I live in Arlington, Virginia, and I have family members and friends that are in associations, the American Pharmacy Association, the American Physical Therapy Association, and I know PTs have been really involved in helping our COVID efforts at MedStar, but really trying to get the message out to related disciplines about what AHRQ is doing and how the research opportunities that are coming forth really are applicable to disciplines across the healthcare delivery system. And I'll continue to think of other ways.
That's great. Thank you. Raul.
Hi, thank you for having me. As I think about it, I think one of the ways is to potentially look at more webinars as we do ours in our own organizations and institutions, perhaps to also then AHRQ also think about having webinars that are out to their sort of constituents, and definitely then we can host those recorded webinars on the websites of our institutions to be able to disseminate that type of information. So it'd be nice to have those recorded webinars that we could just plug those into the website. That when people come to our organization's website, they can also have access to what's available through this webinar and other opportunities on our websites as well.
Well, that's a great idea. Thank you. Mai?
Hi.
Hi.
I always wonder a little bit about the balance between, sorry, I apologize for the construction noise in the background. The balance between whether you think your primary end users is the research community or clinical care decision makers at organizations or frontline clinicians. I think if it's the latter two, there are a host of opportunities to form new partnerships. I'm happy to help broker some of them, but it would include organizations like not just medical societies, but practice organizations like MGMA and AMGA and CAPG. It would include associations of hospital executives and the Blues Association with its ranks of chief medical officers and AHIP and such. I think there's a whole universe of people out there who should be making use of AHRQ's products that actually don't know it exists.
Great, thank you. I see that Peter is back online, so I'm going to go back to Peter. Peter, I'd love to hear on how you think you can leverage your position and your communities to think about how can we better disseminate AHRQ's message and reach other stakeholders to let them know the importance of the work they're doing and their mission. Peter, you're on mute if you're there.
I'm just talking.
There you go, Peter.
Hello?
I hear you now.
Oh, you can hear me now? All right,
Yeah.
Sorry. Oh, you gotta love technology. Yeah, sorry. So yeah, just briefly, I would say absolutely. I think there are numerous ways. So through the other, and others have said similar things, through the other professional societies, for instance, the opportunities to, I think, connect to the work that AHRQ is doing with advances in informatics and the like through the American Medical Informatics Association, certainly something we can continue to reinforce. I think as we are considering, particularly in this new world, more virtual activities, I can think of ways of co-sponsoring webinars or other kinds of activities that would be very specific to AHRQ's focus that I think would simultaneously raise visibility and engage a broader community. So I think that would be helpful, certainly locally with a lot of the work that we do at my institute, but then also more broadly across the region and with national consortia. Just continuously trying to think, I think as David said, about opportunities where not only do we leverage what AHRQ has done and the resources that it makes available and shine a light on those, especially when we're engaging with our stakeholders, including those who are our representatives in government, but also with our colleagues as we're planning initiatives, and then bringing those opportunities to AHRQ so that we can partner. And finally, I've said this in previous meetings, but I'll say it again because I think it's very relevant now. You know, a lot of us are having conversations with multiple groups, including private sector groups, you know, whether they're smaller companies or large ones like Microsoft and Google and others that are trying to really help and figure out ways they can leverage their infrastructure to create data sharing networks and the like that fall squarely into the realm of what AHRQ really influences. And I think that's where some of us can make connections to allow us to leverage those enterprises as well. So I'll continue to think about it, but those are the things that come to mind.
Thank you, Peter. That's great. Excellent. I see Karen has just got back online also. Karen, any comments on how you can think about, you know, the dissemination of AHRQ's message and how you could help reach out to other stakeholders to share AHRQ's message?
So I think Peter mentioned the opportunity for public-private partnerships, and I don't know, as you consider the grants, whether or not that becomes a criteria in terms of weighting the funding opportunities. I think the other area that might be considered for funding would be to think about creating, like the learning health system, but more of an innovation health system where you are funding systems that are creating sandboxes, for lack of a better word, where these partnerships can test and rapidly proof the concept and therefore move to a scaling opportunity for some of the innovations, particularly that are going to happen in the digital health setting.
Great. Thank you so much. Dr. Raju.
Can you hear me now?
Yes, we can.
Okay. Two things come to my mind that we can actually use the NAC members and other friends of AHRQ to represent and spread the message in local and national medical meetings. That could be an area where we could get the message across. And also, some of us do have a very prominent social media presence. So that could also be helpful to spread that message through that media. But you need to empower the NAC members to be the ambassadors of these messages.
Yes, so true, so true. Thank you. Edmondo, we still have you online?
I'm here.
Okay, perfect, great.
So the challenge of being near the end of the alphabet is that all the good ideas are already out. So I mean, I heard Karen, Mai, Peter, Chris, Kathy, multiple people mention partnerships, collaborations, and quite frankly, that's where my mind immediately went when you asked the question, Tina. So I'm thinking, and I heard a lot of different potential partnerships and collaborations. I'm thinking of one particular. Again, I'm the digital guy, right? So I'm thinking about a new society that I actually helped stand up and has really taken off, called the Digital Medicine Society, or DIME. And part of what we're thinking about here, and I think this goes in with the new division that was just presented to the NAC today as well, which is we actually are still defining what digital is, as well as establishing what the true research agenda should be. I think there's an opportunity here for AHRQ to step in and really drive the bus on what digital really looks like moving forward. But I think that does need to happen through collaboration. So I think this is a really good time to potentially seize the bull by the horns here.
Yeah, absolutely. Thank you. Patrick Romano. Not sure if Patrick's still online. Okay, and let's go on to Yanling.
Yeah, thank you, Tina. And I think what struck me, there's one caller had a comment that how public is not aware of some resources or don't understand or not follow the infection protocols, simply like a washing hands, all that. And I think it's definitely true. There's still tremendous work to be done to educate the public about infection prevention, especially during this coronavirus outbreak. And there have been lots of public resources out there. And we have been putting out as fast as we could those resources we can to educate the public about the things that they need to do to protect themselves. And we will continue to do so. And also, I would highly encourage the agency AHRQ and to put out some information out also for the general public, because in my experience, I have found people really looked up the AHRQ's information for general public, and they have a great resources, very simple, easy to understand, and I would continue encouraged to do so during this pandemic. And we were linked to those resources once you put out, and so that people are more aware of what AHRQ is doing also. Thank you.
Thank you. And I'll just add my comment. We're talking about partnerships and dissemination at conferences. I know that AHRQ has a very strong presence at Academy Health, Datapalooza. There's so many other more conferences that could benefit from hearing your message. And I think it would be, taking advantage of the AHRQ, the NAC memberships across different societies to really help, get AHRQ's message on the agenda of those meetings. I'm thinking of AMIA, there's the, Diagnostic Error Society. There's so many opportunities where we can help disseminate that message. So we have a comment from Andy Massica. Do you have a comment you would like to add at this point?
Yeah, certainly, just one. And this is something that I think can help in much more of the acute phase, and that would be a request for AHRQ to double down on what they're good at a time when it's most needed, and that's implementation and dissemination. We're obviously seeing a lot of recommendations, clinical recommendations from the WHO, the CDC, but nowhere is sort of the process of how you stand these things up quickly, the implementation, the deployment, the dissemination. That isn't really out there. I think AHRQ fills a gap, and I would just say doubling down and issuing some of the work that's already been done through usual channels we are at a time where emails are getting forwarded all across the country. So just a normal release, I think, would get much broader circulation than it would normally. So just that's something that can be done now.
Great point. Thank you for that comment. I'd like to ask any of the ex-officios if they have any comments.
This is Mike Lauer from NIH. Congratulations on getting the announcements up. I see them in the guide. And I hope that members of the NAC will widely advertise them. And I hope you get a lot of very good applications and get to do some good work. Thank you. It's been a good discussion this afternoon.
Hi, this is Robin Wagner. Can you hear me?
Yes, we can.
Great, thank you. I think one thing that has not been mentioned is the partnerships that you already have, like the new Patient-Centered Outcomes Research Trust Fund. There might be opportunities to go through the pretty extensive partners that that network has to reach the public.
Yes, absolutely.
Thank you, that's it.
Sure. Other comments from our ex-officio members? Okay. Okay, so with that, I would like to turn it over to Gopal Khanna and have him please comment on this excellent meeting and large amounts of information we've had discussing this afternoon. Please. Gopal.
Thank you, Tina. I appreciate today's meeting very much. And first of all, let me thank you for chairing our first 100% total virtual NAC meeting. So kudos to you. And again, I would love to give a round of big applause, and I know my colleagues would, but it's virtual meeting. So
thank you.
It's nice that this meeting means a lot, and you've done a marvelous job. And of course, when it comes to technology and all the help, Jamie and her team need to know that we really appreciate her work. So thank you, Jamie, and thank you, Jen and Amy, who are helping you as well. I would like to take a moment to thank David, Bob, McNellis, Lucy, who participated in this meeting today. They are great colleagues, and they have been assisted by the entire senior leadership team at AHRQ, who have been just doing marvelous work. So I'm really proud of them. And the AHRQ staff, particularly at this time of crisis in the nation, they have just been outstanding, and it's just a great honor and privilege to be serving with them. And finally, last but not the least, most importantly, NAC members. I am grateful for a very exciting and invigorating conversation. This has been a rich conversation. I have walked away, and I know my colleagues have as well, with a lot of terrific ideas that we can start incorporating in both our tracks. Responding to the COVID-19 pandemic crisis, we are building up our own various strategies to respond, leveraging our current core competencies and assets we have, as well as looking at how we can scale it with your help. And the second track that we talked about, the 21st Century Care initiative of ours, I appreciate all the endorsement and support I have heard in today's conversation. So thank you for that. We'll incorporate your ideas and make them even richer. We'll get back to you on both these topics, 21st Century Care as well as COVID-19 response, and then enlist your help to amplify this message. So your willingness to help is gratefully appreciated. Thank you so very much, and I'm really energized by this conversation. Look forward to seeing you again in later this summer. So thank you, Tina. Back to you.
Thank you. And so again, I just want to echo Gopal's comments and thank everyone for making this meeting happen. Thank you, Gopal Khanna. Thank you, Lucy Levine and David Myers, for your presentations. A huge thank you to AHRQ staff and particularly Jamie, who's been guiding me through my new role and helping me get things working. Thank you for all the NAC members who joined us via WebEx. Please mark your calendars. The next NAC meeting is July 14th, 2020. And with that, I would like to ask for a motion to adjourn this meeting.
So moved.
Second.
Lovely. Thank you so much. Please, anyone, if you have questions, email them. And thank you all. Have a wonderful and safe afternoon. And thank you for your comments.
Thank you.